Oh, welcome to the Aging Boomers. I'm your host, Frank Sampson. Of course, as most of you know on this show, we discuss so many important issues facing boomers, their parents, and what we know, of course, is an aging population. Before I introduce our guest today, I want to remind everybody that today's show is sponsored by Senior Care Authority, a professional senior placement and elder care consulting organization that has a national network of advisors to help in determining the right path for senior living, receiving proper care, or if you just need an advocate to help you through a complicated healthcare system. So whether it's in-home care, assisted living, residential, or memory care, get the necessary advice from a senior care advisor in your area by calling Senior Care Authority at 888-809-1231. Or you could go directly to the website at www.seniorcareauthority.com. We're going to be talking about an extremely important subject matter today. We always do, but this one is making a lot of news. And so I'd like to introduce our guests. We have with us Karin Kidd, who's an RN, co-leader for the Greater Northern Bay Area for the organization Compassion and Choices. Karin has been a registered nurse for 45 years with a focus on oncology, reconstructive surgery, medical ethics, and palliative care. Karin now serves as a volunteer educator for the public and medical professionals in order to understand the legislation End-of-Life Option Act and how to access it. We also have with us Dr. Dennis Pocekay, I hope I got that right, who's practiced at Kaiser Permanente in the Bay Area for 28 years, is board certified in internal medicine, geriatrics, preventive medicine, and occupational medicine. Since retiring from Kaiser in 2009, he has advised high school students interested in health careers, taught introduction to public health to undergrads at UC Davis, and mentored first-year medical students at the Paul Horn Asian Free Clinic in Sacramento. Dr. Pocekay is also the volunteer educator for the End-of-Life Option Act. So Dr. Pocekay, Karin, I just want to thank you so much for joining us on the Aging Boomers.
Thank you. We're glad to be here.
Yes, indeed.
Yes. I didn't botch up your name too bad, did I, Dr. Pocekay?
No, perfect.
Okay, good. So maybe one of you could start out just telling us more about the organization called Compassion and Choices. Tell us more about that.
All right. Well, Compassion and Choices is one of our nation's oldest and largest nonprofit organizations. They have been working to improve the care and to expand the choices at the end of life through supporting individuals, families, doing this through education and advocacy at the local and national levels.
So even though you are based in California, and we're certainly going to be talking more about the California End-of-Life Option Act, Compassion and Choices is a national organization.
Correct, yes.
Okay. All right, good. So tell us more, and I know that I know we have listeners from all over the country and even outside the U.S., but this End-of-Life Option Act in California, I think everybody's interested in it because sometimes things happen in California and they start expanding to other states as well, even though I know this act or a similar act exists in some other states. But tell us, what exactly is the California End-of-Life Option Act?
Well, here goes. The act itself authorizes medical aid in dying. The law allows a mentally capable terminally ill adults with 6 months or less to live to request aid in dying medication from their doctor for self-administration. If their suffering becomes unbearable to bring about a peaceful death, this may be one of the several options available to them.
Okay, so let's get maybe into some more specifics. What are really some of the legal options available to them at the end of life?
So, Frank, there are multiple options available near the end of life. Of course, the first one is that patients have the right to discontinue or refuse medical treatment. More and more often, patients who have a terminal diagnosis elect to have palliative care, and when things get especially difficult, they may choose to voluntarily stop eating and drinking. Okay. Beyond this, there's begun use recently of a form of treatment called palliative sedation, where the patient is basically rendered unconscious so that they do not have any unbearable pain or suffering. And finally, beyond that comes the act that we're here to talk about, which is the End of Life Option Act, which allows the patient to request medication to provide them aid in dying, in effect, to allow them to die on their own terms.
So
one thing about the Oregon Act, as you mentioned, our act is patterned after the Oregon Act, which required, as this one does, that physicians discuss all these options with patients who request medication. And in fact, the experience in Oregon is that over 20 years, that more and more people over time have taken advantage of hospice and palliative care based on discussions related to this act.
Okay, so there's I guess there's a lot of questions I have, but I'm just going to start with, as you know, in the field I'm in, we're dealing with seniors mainly, okay, and people, as you know, are living longer. They're beating other diseases, and which has increased the chances of people getting some cognitive impairment like Alzheimer's and other forms of dementia. So how does that work? I mean, it's kind of, you hear about when people know I'm in this field, they say, hey, if I get Alzheimer's, just put me away, all right? But it's not that simple with this act. Is that correct?
That's right, and the short answer is that this act offers very little to an Alzheimer's patient. I mean, Compassion and Choices does have a form that you can complete as part of something they call the Good to Go Toolkit at their website, which allows you to express your opinions about what should be done for you if you get Alzheimer's. But this act does not cover that. It truly, the short answer would be that the act probably couldn't have passed the legislature if it had been that extensive.
So
also, it might be good to note that to be eligible for this act, you need to be an adult of 18 or older, and of course the information has shown that it has been most used by people of 65 or older. Be terminally ill, which usually mean having been given a prognosis of 6 months or less to live, and mentally capable of making their own health care decisions. And that's what Dr. Pocekay maybe can address. What does that mean?
Yeah, what I would say is that the only way this can truly help a patient with Alzheimer's is if they have mild Alzheimer's, so they can still make a medical decision, and then they develop cancer and then have less than 6 months to live.
So if somebody who has Alzheimer's, all right, and they, are certainly aware of this, they're still of sound mind. They can't legally put in writing or have their power of attorney that once a doctor has given that individual 6 months or less to live, that person probably isn't of sound mind anymore, okay? And it doesn't work that way, I take it.
Right, you're absolutely correct.
Okay. Why do you think that is?
Well, if we think about coming from the point of the legislation itself, the reason why this is so successful is because it is a trusted practice. There has not been any known cases of abuse as a result of it. Mm-hmm. So I think it's very careful this is a beginning.
Right.
To address the fact that there does need to be two physicians to determine the capability of that person to make a sound health decision for themselves. Not a power of attorney, not a family member, because this is voluntary, not a means of others utilizing their power over your values and decisions and will.
Got it.
Does that help a little bit?
Oh yeah, absolutely. So what's the process for an individual? Let's just say that they are diagnosed with a type of cancer that, maybe they're at a stage 4, and they just, obviously we're beating a lot of diseases nowadays, but it just gets to the point, they want to start to prepare that I may get to the point where I just don't want to do this anymore, all right, and I can't, and I don't want to suffer anymore. So you could kind of prepare until that 6-month period hits. Is that kind of how it works?
Well, let me go back a little bit, Frank. I really think the most important point we have to make today is that you shouldn't wait until you have 6 months to live. If you think that your approach to life or philosophy of life will take you in this direction at any time, you should make an appointment or call or email your doctor right now to find out, number one, if he is receptive to this idea, and number two, whether he'll actually write the prescription. Because what we found certainly in our counties as we've gotten started as after the law took effect on June 9th, is that even though 2/3 of physicians were in favor of the law, that well over half of those that are in favor of it don't want to actually take part in it. And so there have been some difficulties in accessing the law, such that some patients have had to utilize physicians making house calls from, in my experience, as far as 50 miles away.
So what you might, I have a sense that what you might be asking is, how do you access just this whole idea?
Right.
And we're advocating that we want to encourage people to have conversations now with their families, the people who care about them, and specifically their doctors, so that if a physician is not supportive of writing the prescription at the time that you might need it sometime in your life, end of life, you have the choice of changing or finding another support. But if you were in that situation of, wow, my doctor just told me I have 6 months or less to live, I don't know if I would want to utilize the medication option, but there are many other options also, as Dr. Pocekay described. The first step is to make that known. You need to make a verbal request, and it actually takes a total of 3 voluntary requests, 2 oral that are at least 15 days apart, and 1 written to access this process. I think what we're starting to see is that it's very important that once you've made that first verbal request, you need to quickly go into the process of meeting with the physician and finding out in depth all of your options, and being evaluated. Sometimes your physician may not be completely comfortable with their own assessment and might want to call in an additional mental health professional such as a psychiatrist or a psychologist. So that can all be done after that first request and in that 15-day waiting period to your second request. Does that make sense?
Absolutely.
Right.
So really the first, we'll share with people websites they could go to learn more, of course, but your suggestion is the first step is have that conversation with your doctor, of course, after you've had it with your own family members, hopefully.
Exactly, and it is important to stress with your physician because no one but you can really make this request, as I said earlier, and it must be to your doctor, not to their office staff, not to the hospice nurse per se, or anybody else. But it's important that it's that one-to-one between you and your physician.
Okay.
You see, there are multiple steps here that I think we're getting into now too. In that once you talk to your physician and you're waiting 15 days to make your second verbal request, there are things that you can push the physician to do. If the physician's inexperienced, he may be waiting for all the requests to take place before he refers you to a second physician, because you have to have a total of 2 physicians declare that you meet all the requirements of the Act, and either or both of those physicians, as Karin said, may require you to speak with a psychiatrist or psychologist as well. And so you've got at least 2 and up to 4 medical decisions that you're requesting others to make. And so if you wait until after your 15-day second verbal request, it might take another 2 or 3 or 6 weeks to find an appointment with that second physician or with the psychological specialist.
And of course, the importance to that is that none of us have a crystal ball. We don't know how quickly the process will go in regards to the individual's physical demise, or some people have been on hospice for quite a long time, many months. Others, it may be only 2 or 3 weeks. So that's why the urgency in going forward with the processes as easily as possible.
So are there any assurances, there's no guarantees, obviously, in the medical field, but to give people a comfort level that should they meet all the requirements, that the procedure or the options, maybe you could talk about the options of the various procedures, that would certainly be painless. Can you get into that at all? I'm sure that could worry some, especially family members, who say, I don't want mom to suffer at all during this process. So maybe you could address that.
Sure. The most commonly used, I presume you're asking about the aid in dying medication.
Exactly.
And the probabilities of different outcomes once you take it. Okay.
Right.
So the standard medication is called secobarbital, and the issue, and it is very effective. 99+% in Oregon. Okay. The vast majority of the time, the patient passes within an hour, falls asleep gradually, and passes within an hour. Although in 10% or so of the time, the death can take a few hours to happen. We're not sure that this hasn't been researched to a great extent because of the writings of the various laws, but we're hopeful that we'll be developing more research in this regard in California. The other issue with the medication is that as this idea has taken hold in the country, the company that basically owns the rights to producing the secobarbital has increased the price by on the order of 500% over the last few years. And talking $5,000 for a dose, if you're talking about a pharmacist calling the company from their own small pharmacy. Big organizations like Kaiser or Sutter here in California, I'm told, can get the medication for about $3,500 per dose. And there are a variety of cocktails being used, experimented with, if you will, in Oregon and Washington, which can reduce the price to less than $500 a dose by combining several medications. Kaiser and Sutter, I believe, will cover the cost of the medication, less whatever copay the patient may have. But for a patient who has private insurance, there are issues with that because it takes time for the insurance companies to decide to cover this sort of thing.
Okay, all right. And
you mentioned, though, about suffering.
Right.
I think that's a key word here. And what we are encouraged about is the fact that with this new expanded awareness and now this new legislation, it would be hoped that the tools of hospice and palliative care would be more available to patients. Palliative care refers to comfort care, as hospice are specialists in pain management, among so many other things. So that would be one other thing that we would probably be seeing in the future is hopefully physicians ordering hospice care sooner than later, and that the palliative care possibilities have also been initiated. So there's so much we can do to reduce or alleviate, per se, suffering, which is an individual perception also, so that we're not advocating or stating that everybody should utilize the medical portion of an option, but that we have another choice available.
So, as you know, we have people listening all over the country, and I say even outside the country. So those that are listening, and they, as you mentioned, this law exists in Oregon, it now exists in California. What if somebody in another state who they don't have this law in their state, but the family feels strongly that they want this option for their loved one? Could it be done by them coming to California or Oregon?
Well, the one thing I would just say first is the individual must be a resident of California. I mean, there were people from California who went to Oregon. Besides you being, voluntarily wanting to do this, you do have to show proof of that residency. So whether that would be number one, you can't just be transferred to another state and initiate it. But there would have to be some proof of residency, whether it be through driver's license or other type of formal proof. Also,
It's
go ahead. 5 other states right now.
Yeah,
and we're working on the other. So there are more and more states that this will be available, but that's why I said we're in the beginning.
Right.
Frank, you brought up the point you brought up. I think it's important to add that a big, not certainly the only reason, but a big reason the law was passed in California at this time relates to the California resident Brittany Menard, a young woman with brain cancer who moved to Oregon to access their law last year.
Mm-hmm. Right.
And I believe that had a fair amount to do with passing the law at this time. Another part certainly is that public opinion was altered by that, and thirdly that the California Medical Association adopted a neutral stance as opposed to in the past they've always been against it.
Got it. So I know you were kind enough to send me a little information that I could review about this before our interview, and there's a term that's used called 48-hour attestation. Can you explain that a little further?
Yes. This is simply a form that the physician gives to the patient, and that they are supposed to complete and get back to the physician within 48 hours of the time they intend to take the medication. I believe this is to allow physicians to make reports that they need to make about the results of writing the medication prescription. There's nothing written about a penalty for a patient or family that doesn't do that, but that is to help with the data collection for the State Department of Public Health.
So going back to what you were saying,
it also is just to once again to address the awareness of that patient is completely aware of the consequences of taking the prescription. So it's just another safety in there. And I do like to also remind everyone that just because prescriptions are written and medications are obtained does not mean that they have to use it. So you can withdraw your request for the aid in dying a drug, at any time.
Right. So just on top of this 48-hour attestation, just to make sure a family, and I'm sure they'll be advised of this by their doctor, etc., but just to go through it, because Dr. Pocekay, you mentioned that, insurance paying for this and all of that would be all kind of already pre-approved before this 48-hour attestation period, right? The person's not going to run into a bunch of red tape within that 48-hour period. No, not at all. This
is something that's left to the patient. No one is standing over his or her shoulder to be sure that this is done or it's done in any particular way, but it is something that the law requests. Got it.
Okay, good. Well,
one other point I want, if I could make it, Frank, I'm concerned we're going to be getting to the end of our time, is that the patient requires, when he makes his written request, to have two witnesses, that he is basically saying that the patient is of sound mind in making this decision. This is not related to the 48-hour attestation, but it's related to the three requests he or she must make of his doctor, okay? And the important things are that one of those two witnesses can be a relative or someone named in the patient's will who might possibly benefit from the death of the patient, but one cannot be, okay? Similarly, one of those two witnesses can be a manager or owner of an assisted living facility the patient is in, but not both, okay?
Got it. Okay. So you bring up an important point. I assume, based on what you're saying, I would assume that life insurance, things like that, are not affected by this because of the laws. Am I right?
Yes, that absolutely is the case, and equally important, the law says that the cause of death will not be recorded as suicide or assisted suicide, but that the cause of death will be recorded as the underlying disease.
Got it. Okay, good. Well, you've been a wealth of information, both of you, and I really appreciate it. I'm sure many of our listeners have learned quite a bit about this, and you've been very helpful. If you could share also, we got just a few seconds left, but take your time. Give us kind of the websites that people could go to learn more.
The main one would be Compassion and Choices, spell out A-N-D, compassionandchoices.org. There are a variety of pages at that website, including the Good to Go toolbox. It helps you state your preferences for your end-of-life situation. There are references to the doctor-to-doctor that you could refer your physician to if they seem to need help in helping you. Also, a pharmacist-to-pharmacist that could be utilized if there's an issue with getting the prescription filled.
I would also like to mention that we, as volunteers, speakers, are available to come out and speak to different groups, whether it be a group of people in your neighborhood that you got together, or through churches or mobile home parks or wherever. But we are available to come and to educate people on the legislation, how to access it, and be of assistance in that regard.
Great.